Thanks again for having me back. And really, Sherry's right. This is just sort of an extension of the talk I just gave a few minutes ago. But now we did 1.0 surge, we did 2.0, and now we're going to go hopefully to 3.0 surge. So as I was coming in yesterday, I got emails from my team saying that our hospital now has 35 patients in the emergency room waiting for medicine. I'm like, oh my gosh, I feel kind of silly. I'm about to go and give a talk about how we dealt with surge, but guess what? We're still dealing with it. It seems to never end. This was tsunami surge. Okay. Hopefully, by the end of this talk, we have 5 more strategies for managing extreme surge, which we've called now tsunami surge. Okay, so you'll remember this slide, guys. This is what we did back in 2010 when we expanded procedures, staffing, and the hospitalist, staffing for the care managers. And we got our discharge huddles together, discharge before noon initiative, all that stuff is humming along. Surgeries on the weekends, yay. And we managed our flow, no more patients coming in inappropriately, hopefully, people coming from outside hospitals only when we can do a procedure that the sending hospital cannot. We've gotten our flow together during the hospitalization, and we have a really great process for discharging patients as safely and as quickly as possible. And we're loving our results. These are the ones that I showed you a little bit earlier. Our ODE length of stay is 0.79. We've squeezed every little drop of water out of the stone, and we're feeling really good about ourselves, thinking, hey, we can take this on. But then we get to January 2024, and it sounds like this is a theme amongst a lot of people here, that the volume keeps expanding. And every 6 months or so, I go to the dean and we do our snapshot presentation to the dean. And I feel like I say it almost every time that our volume is up 30% from what it was the year before, and that was up 30% from the year before that. So we're not just building new hospitals, so how the heck are we increasing this capacity in a fixed system? So how are we working even smarter? And he pushes us to work even smarter than ever when we think we've tried to do as much as we possibly can. So here you see the numbers that hospital medicine, again, the bulk of the medicine service, there's a small cardiology, small hem-onc. Gen Med is more for like sort of the nephrology patients that are under a different system, and then the pulm critical care is the ICU. So hospital medicine, the team that I am in charge of, has the bulk of the practice. So as we do well, the whole service, and frankly, the whole hospital does well. So that's why, when I was speaking to some people in the halls about their hospitalists not feeling valued, that makes me so incredibly sad, because hospitalists have such value. As our ED friends and our ICU friends, we provide so much value to the hospital. And so that's why we can't let this narrative be, and sometimes the hospitalists, and I've had to combat this, the hospitalists are not doing a good job. And I'm sure some people are saying, the ED docs and nurses aren't doing a good job. Well, that's just not true. And that's where data comes, and really great leadership, which we just had the prior presentation, to really change that narrative. And I've had to do that pretty much the whole time I've been the director for the hospital service, with data and an aligned vision. Before I get to all this, an aligned vision couldn't be more important. That's why I have leadership meetings with my senior leadership team every 6 months. I kind of call it the hospitalist infomercial. I don't tell them that, but it's like I have all the hospitalists, and it's a grassroots meeting with the senior leadership, the COO, the CMO, my chair, because we're all integrated. My hospital boss and my academic boss are 2 different people, but I respond to both of them. And I basically make a great presentation on the 3 mission areas, the clinical, the research, and the educational efforts that all of my hospitalists have been doing over the past 6 months. And it's just basically a rah-rah talk about how great the hospitalists are. And at the end, there is an opportunity for my frontline hospitalists to ask, and I make sure they're constructive questions. We don't want any nasty questions or questions that don't portray our image as leaders and as solution makers, et cetera. So, but they get to ask questions to the people who are helping us make decisions at the top. So it feels more like a team. That being said, when the dean says he wants this and this, this and this, it's my job as the middle leader to try and enact it. And that's where, as the prior presentation, the leadership really comes through. And being, an authentic leader, being someone who's super transparent and sometimes very, very vulnerable, that has also worked for me. So even though this is not part of my presentation, I really say to my team, I tell them this is who I am, and I encourage people to kind of write down, like, who are you as a leader? So for me, I'm a mom, doctor, mom. I'm a working doctor, mom, and everything I do has to do with either work or being a mom. And I have 2 German Shepherd dogs. I go to soccer games, so don't talk to me in September because I'm on the soccer field. And I'm a breeder, and I try to make this world a better place. That's it. That's a nutshell. That's who I am. So my team knows me as the immigrant mom, worker, all that other stuff. And so they know who I am. And I know all that little snippet about each of them. It helps me relate to them. It helps them to relate to me. Okay, back to Surge. So we've done all this stuff, but Surge keeps growing. What the heck do we do? All right, here's strategy number 1. I'm sure people do this, but these are pop-up units. So everybody wants to thread the needle, right? You don't want to have a whole unit that's not used most of the time, where the nurses aren't being used. And, you want to have a unit when you want it, and you don't want it when you don't want it. So we have created pop-up units for times of these tsunami surges. You'll see this is just a timeline of how we've expanded over the years. So the latest pop-up unit is 12 West, and that's 16 beds. And we sometimes need it, we sometimes don't. Now you probably are asking, well, what the heck is 12 West usually? And for us, at least in New York City, our deliveries are down. So this is the labor and delivery floor where they're really running at kind of a 50% occupancy. So during that time, if we need those beds, we will take half of those beds, those 16 beds on that one unit, and take those for medicine. Remember, it's geographic. We're very strict about geography. I think I get to that in one of the other talks. We're very strict about geography, so we assign a hospitalist. But your question probably is, well, where is this hospitalist coming from? We don't just have hospitalists lying around. What we've created, and again, this had to do with my conversations with senior leadership, is that we created a Jeopardy pool for the hospitalist service, much like we did in residency. The residency program has it. So we have a person who's on call, who gets, that's their shift, they get their credit, whether they get called in or not, and more likely than not, they are getting called in every day. So we have somebody to staff the shift at any moment, and that's 16 beds. It doesn't help all of Surge, but it helps much of Surge. So if you take 16 beds off of when you're at 34, well, now you're down in the teens again. So it helps. And these are the patients that we also have care management and social work. Everything pops up. So we pop up to this unit and try to get patients out. When we don't need the unit, it closes off, and then it goes back to whatever it was. But this is an example of how we pop up a unit in times of tsunami surge. My guess, by the end of the next 2 or 3 months, this will end up being a medicine unit, because all these other ones started off as pop-ups and are now medicine units now. So this is, I think, just what happens before it's actually a permanent unit. Okay, this is one, and I'd love people's feedback here because this isn't done everywhere. But we have an ED surge hospitalist. So I mentioned in my prior talk that we really partner with the ED team. We understand that their chaos is ours and vice versa. We really do try and help them. And we do that by saying that when a patient is admitted to the medicine service from the emergency room, that patient is now medicine. The emergency room doctors do not have to deal with that patient any longer. The ED nurses do. So now we have my hospitalist, who's a medicine person, dealing with the ED nurses to care for a patient who is coming to medicine, but there's no beds yet upstairs. We call that person the surge hospitalist. That person, as was mentioned in one of the prior talks, we have our little script too. We basically say, listen, I'm Dr. Hochman. I'm the hospitalist who's down here working in the emergency room. There's no beds yet upstairs, but I'm going to begin doing everything that the person upstairs would be doing, but we're doing it down here. It takes the pressure off the patient. They immediately relax. We are doing the stuff anyway. We're doing the fluids and the blood and the procedures and all the consults. All of it's coming, but it's now happening in the emergency department. This person we have 24/7, 365. It's the hardest role of all the different shifts that we have for our hospital medicine team. Just like was the prior presentation, servant leadership, I do my time down in surge, my week of surge, and it's really, really hard. When it gets really tough, we bring in that Jeopardy person. If they're not working on a pop-up unit, we'll have them come down and help us out here. But it's tough. These people, what I love about this is that it preserves geography. So it would really be disruptive to the teams upstairs. Remember, I said when I'm on 17 West, I don't even want to go to 17 East, let alone down to the ED. No way. That would take up a lot of time, and it would be very disruptive. It would prevent me from getting patients out that would help the ED. If I get patients out, that's going to help the ED decompress. So that's why we have the surge hospitalist, because we're geographic. We can't assign a team before we know the bed. The bed is linked to the team. This surge hospitalist is really, really active in managing with the ED care manager. We have some outstanding care managers down on the ED, and they're the ones that are scouring the list saying, nope, this person doesn't have inpatient admission criteria. Let's put this patient in observation. This person doesn't need to be here. Let's get them home, and I'm going to help you get them. Let's get the social work. Let's get services, blah, blah, blah. This person is, I literally, instead of like upstairs, I round with my APPs or my house officers. Downstairs, when I'm doing surge, I round with that care manager. We round on all the surge patients, and we just kind of get it done. And we make disposition plans for all of them. We often discharge patients from the ED. Sometimes time has elapsed. Studies have come back. Things have changed. Patients' minds might have changed. There may be an opportunity to get a quick outpatient visit. Things have changed. So as the ED surge person, I'm often discharging patients straight from the ED. That's fine. We also re-triage patients to other teams. So like say, for example, I always use that kidney stone example. Somehow that's coming to medicine. I will say, oh, don't forget about the admission criteria. Let's get that patient to the right place. So it's all sort of a work in process. We care for about 15 patients, and as I mentioned, if it gets super crazy, we bring in another person to help out. We have two kind of wings of our DED, so usually it works out that one person takes one wing, the other one takes another wing. So we're kind of geographic down there as well. It's a very, when I do the other talks about this, I sometimes call this person the sacrificial lamb. It's the hardest role. It's the person who has the hardest job. And unfortunately, and I haven't been able to convince my senior leaders about this, there's no APP support for the surge hospitals. So it's essentially attending only. I don't have attending only in my practice, except for down there. And in my opinion, that's incorrect, because these patients are the sickest, they're the least differentiated, and there's a lot of them. So an APP would be very, very critical. So if you do this, make sure you talk to your senior leadership about creating a model with a hospitalist and APP and a care manager. That trio would be a power trio down there. And that's really saved us on the wards. Okay, so that was number 2. Number 3, okay, this has to do with tracking estimated discharge date. Is anybody doing this in their practices? Okay, a few hands. All right, so we're really trying to get good at estimating when the patient will actually be discharged. This is really important because it has to do with staffing. So if we know we're in terrible surge right now, but we're expecting 55 discharges tomorrow, we're probably going to be okay. But if not, then we're going to be in tsunami surge, and we got to get people prepared to come in. So this is more of a staffing solution or staffing information gathering. But it also makes teams put their line in the sand. Do you think this person is going to be ready tomorrow, yay or nay? And if once you say the word yes, oh yeah, I think this person can go tomorrow, then that triggers things to happen. Like, oh, well, if that's the case, then did we do the DME? Did we do medications? Did we do services? Did we do all this other stuff? And it gets people really thinking about discharges. And you can see, we were actually pretty bad about this earlier. In January, we were getting decent. I wouldn't say spectacular, but overall, we are 77% right in saying the day before, oh yeah, this patient's going to go home that next day. So 77% of the time, we get that right, which means, there's 23% of the time we don't. But anyway, it helps with tracking. And I should mention, sort of as a corollary to this, I didn't put this as its own separate strategy, but maybe it is. We have really, really fantastic medical directors on each of the floors. We invest heavily in our medical director and nurse manager dyads. So for like a unit of 34 beds, roughly, we have one hospitalist who 0.2% of their time, so 20% of their time, is bought out to be a medical director on the floor. Their job is they work most of their clinical time, they will work on their floor, that they're the medical unit. And their job on their non-clinical time, remember I said you're not off in Hawaii or Orlando on vacation, you are working in the hospital. So they will come at key times, at interdisciplinary rounds, sometimes the afternoon rounds. They will round with the nurse managers, doing patient rounds. Sometimes they have to do service recovery rounds. They have to understand, I call them the chief of the unit. They need to know everything about their unit, whether there's staffing issues, difficult patient scenarios, if there's any hacks or hospital-acquired conditions that occur on their unit, you better believe they're in there understanding what had happened and will making recommendations for it not to happen again. They also report to senior leadership on a actually quarterly basis regarding metrics like these. And they're held accountable, as was said in the prior presentation. When I hire people, I say to them, hey, we have our vision and mission is to create outstanding patient outcomes for all of our patients. And in order to do that, you have to remember, but you have to realize that when working here, we're a highly metric-driven organization. I give my hospitalists report cards every 6 months, not to be nasty or mean, but to say, this is your data. Now, by the way, they can get their data anyway because it's on the dashboard and they can look at it any time of morning or night. But we actually present it in a little, mini report card. We list it out. We list what the average of our team is and where the deltas are. And it's just the beginning of a conversation to say, hey, I noticed that your O to E length of stay was 0.9. Everybody else's is 0.75 or whatever. Talk to me about that. And you'll get, discussions like, walk me through your day. Well, many of the junior hospitals, maybe they get in early, but they spend the first 2.5 hours on the computer looking and trying to round and pre-round and all that stuff, as opposed to just getting up and starting the day, calling those consults, doing those things that need to be done in an early manner. So estimated discharge day is an important strategy to help plan for extreme surge. It doesn't prevent surge, but it helps plan for surge. Okay, I was so happy to hear the second talk about the hospital at home, because this is something that we've also done that has helped reduce the volume on our Long Island campus. We haven't done this in Manhattan yet, and I'm really hoping that we will. So much like the prior presentation, it's a hospital at home. Unlike the prior presentation though, and you started getting toward this at the very end, we don't admit patients to the hospital and then discharge them to hospital at home. These are patients that are coming to the ED that we self-select immediately to go to hospital at home. So their CMI, their case mix index, is actually quite low. So these are people with cellulitis, UTIs, low-level COPD or CHF exacerbations, easy low-level pneumonia or walking pneumonia, things that could likely be successfully treated as at hospital at home. At least for us, you have to live within a 12-mile radius that takes care pretty much takes care of most of the catchment area. It is also staffed by hospitalists, visited twice daily, and they've gotten some amazing, like the prior presentation, excellent patient satisfaction results. Their volume hasn't been as high as the prior presentation, but their OD length of stay is quite good, et cetera, et cetera. So that's great, and I see that happening a lot. I think that there are so many things that can be really taken care of at home, and the patients love it. And one person said they got discharged from their, they were eating dinner and they were discharged to the dinner. So it was actually, easy for them. It was much more seamless flow. So I really hope to see a lot of that, and I hope to see hospitalists, and frankly, ED physicians will be part of this too, because you guys are helping us decide which are the appropriate patients. Okay. Strategy number 5, And this has been a big help for us, which is to cluster patients who are medically ready awaiting discharge. So imagine in your institution, as I'm sure we all have, there are a subset of patients who are medically ready awaiting fill in the blank. Court-appointed guardian, or someone who unfortunately is a drug user and needs IV antibiotics for several weeks. Or there's a whole host of people who essentially take up beds in your main hospital, and it basically clogs up the system. So what we've done is we've taken a subset of those patients, and it's only a small footprint, 12 to 16 patients, and we put those people in an orthopedic hospital that we had that's not at all contiguous to our hospital, but we're on 34th and 1st, they are on 17th and 2nd. So what we say to these patients is that we're going to transfer you, just like you could transfer from 17 West to 17 East here, we're going to transfer from the main hospital to an orthopedic hospital that was running at 70% or 75% occupancy. So there was a lot of space in that hospital, but we were clogged up in the main hospital. So it only really makes sense to move patients over there. So now we have a medicine floor within the orthopedic hospital. And this is specifically for patients who are medically ready. This is the only other service other than surge, which I mentioned a second ago, that is attending only for my hospitalists. And that's appropriate because these people really are waiting for an appropriate discharge and social worker and discharge plan. We have like the A+ social worker and social worker and care manager down there. So they're really, really trying to think about creative discharges for some of these people. And a lot of these, we have a lot of exclusion criteria. So people in dialysis requiring dialysis cannot go here, and there's other ones like that. But particularly, these are medically ready people with complicated discharges, and they have very, very high lengths of stay. So you could see just the impact these people have. So overall, for let's just say December 2023, the observed to expected length of stay was 0.76. That's everybody. But if you took those patients out, only those 12 or 16 patients, if you take them out, we go down to 0.72. So it's a very, very small number of patients that makes a very big impact. So it is one strategy for caring for patients who are long lengths of stay in your hospital. I think that was my last, so this is a little bit shorter than the other one. I think we're on time though. So if anybody has any questions, I'm happy to take them in the panel or wherever we go next. Yeah.